Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about pulmonary vascular diseases, and under that we'll start off with pulmonary embolism. So pulmonary embolism can be divided into acute and chronic subtypes. Acute pulmonary embolism is associated with typical symptoms of dyspnea, tachycardia, and pleuritic chest pain, while chronic pulmonary embolism may be associated with pulmonary hypertension. The diagnosis of pulmonary embolism can be very challenging because the presenting symptoms are both common and also non-specific, including signs like dyspnea, tachycardia, and pleuritic chest pain. Most pulmonary emboli would tend to originate in the deep veins of the thighs and in the pelvis, and the risk factors for deep vein thrombosis may include immobilization for a very long time, malignancies, catheter use, obesity, oral contraceptive use, and thrombophilia. Approximately 25% of patients with pulmonary embolism do not have any identifiable risk factor. CT pulmonary angiogram is the most common method to image for pulmonary embolism, where an embolism is typically seen as a central intraluminal pulmonary artery filling defect. The pulmonary emboli will tend to lodge at the vessel bifurcations. Pulmonary infarction can also be seen as peripheral wedge-shaped consolidations, often with what we would call a reverse halo sign. For a normal halo, you would have an area of consolidation with peripheral ground glass pacification. So now if this is reversed, where you rather have central ground glass with peripheral consolidation or central normal lung attenuation with peripheral ground glass attenuation, that's a reverse halo sign. So if you have this in a wedge-shaped pattern and in a peripheral location, that could signify pulmonary infarction. Pleural effusions also often develop after several days. After congestive heart failure, parapneumonic effusion, and malignancy, pulmonary infarct is actually the fourth most common cause of pleural effusion. So this image is a CT pulmonary angiogram, which shows a large, nearly occlusive filling defect in the right main pulmonary artery here, and that extends distally to the bifurcation. In patients with acute pulmonary embolism, one should always examine the heart for imaging findings of right heart dysfunction, because right heart dysfunction in the presence of acute pulmonary embolism is actually associated with an increased mortality. So some of the findings of right heart strain can be bowing of the intraventricular septum to the left, an elevated right ventricle to left ventricle ratio of more than or equal to 1. That means the size of the right ventricular chamber shouldn't be more than the size of the left ventricular chamber. Now, we have submassive pulmonary embolism and massive pulmonary embolism, and the presence of right heart strain will determine the categorization. So submassive pulmonary embolism would be right ventricular enlargement seen on imaging or clinical signs of right ventricular dysfunction. So you have a pulmonary embolism in addition to right ventricular enlargement on imaging, or clinically you have signs of right ventricular dysfunction plus a pulmonary embolism. Then we'll call that submassive PE. However, to call it massive PE, then there should be systemic hypotension, that is systolic blood pressure of less than 90 millimeters of mercury in addition to the pulmonary embolism. Then we'd call that a massive PE. So once you have systemic signs of low blood pressure, then automatically it's massive. So this axial CT demonstrates bowing of the interventricular septum to the left. The right ventricle is also larger in diameter than the left ventricle, and these are signs of right heart strain. So in the presence of pulmonary embolism without hypotension, would call this a submassive pulmonary embolism, and if we have signs of hypotension as well, then we'll call this a massive pulmonary embolism. Now, while CT pulmonary angiogram is the standard tool to evaluate for pulmonary embolism, it's important to be aware of plain film findings that may suggest pulmonary embolism in case the diagnosis is not clinically suspected. So the first one we'll talk about is the Fleshner sign. Fleshner sign describes widening of the pulmonary arteries due to a clot. Then this is very well correlated to what we call the knuckle sign, which is an abrupt cutoff or tapering of the main pulmonary artery as a result of a clot. However, this is better seen on CT than on plain radiographs. Then the pala sign is similar to the Fleshner sign, but while the Fleshner sign is looking at the main pulmonary arteries being dilated, the pala sign is looking at the right descending pulmonary artery being dilated. If you see that on plain radiograph, that's the pala sign. And if you have an abrupt cutoff of this right descending pulmonary artery, we call that the Chang sign. Now, Westermarck sign is regional oligemia in the lung distal to the pulmonary artery thrombus. So an area of the lung would appear to have fewer blood vessels compared to the contralateral side, and that is secondary to a pulmonary thrombus. The final one is Hampton's hump, which is a peripheral wedge-shaped opacity representing the pulmonary infarct. So this image actually shows a dilated right descending pulmonary artery here. That's the Fleshner sign. And then if we compare the vasculature in the right upper zone compared to the left upper zone, realize that the left upper zone actually appears more dense than the right upper zone, which appears more lucent. And this is because of the relative fewer number of blood vessels seen here. That's the relative oligemia called the Westermarck sign here. Now in this image, we see this rounded, nearly wedge-shaped opacity in the lower zone projecting over the lingula, and this represents Hampton's hump in the context of a left pulmonary embolus. Now to chronic pulmonary embolism. So we've seen acute pulmonary embolism, its clinical diagnosis, its imaging diagnosis, as well as the radiographic findings. Now to chronic pulmonary embolism. Chronic pulmonary embolism presents with signs and symptoms of pulmonary hypertension, as we stated earlier. Clinically, this may also be non-specific, but on imaging, once you see signs of pulmonary hypertension, you can point more towards chronic pulmonary embolism as opposed to an acute pulmonary embolus. So what are these imaging findings we're talking about? Chronic pulmonary embolus would present as an eccentric filling defect or an eccentric web, as opposed to the central intraluminal filling defect that we would see in an acute pulmonary embolus. And you may also see pruning or abrupt cutoff of the pulmonary artery branches. Now, note that as the acute pulmonary embolus resolves, it involutes, and that is what would cause the eccentric filling defect or the webs. It's as a result of the involution of the acute pulmonary embolus. Now, some of the parenchymal findings you would see would include mosaic attenuation, where you have two densities of the lung parenchyma. But in this case, the low density part of the lung would be the abnormal lung, and that's as a result of altered perfusion. And then the relatively higher density lung would be the normal parenchyma. You may also have occasional scarring. Now, in these patients, it's important to look for signs of pulmonary hypertension. And now we've mentioned some of the signs of pulmonary hypertension earlier, same as the signs of right heart strain. You may have enlargement of the pulmonary artery. You realize that the pulmonary artery to ascending aorta ratio would be more than or equal to 1. Then the right ventricle would also be enlarged and would also hypertrophy. You have its walls hypertrophying. If you have all these signs of right heart strain, all these signs point to pulmonary hypertension, it should increase your suspicion of the embolus you are seeing being more chronic than acute. Now, chronic thromboembolic pulmonary hypertension, or CTEPH, is the constellation of chronic pulmonary embolism and pulmonary hypertension. We'll talk about pulmonary hypertension in the next video. These patients are often evaluated with ventilation perfusion scan and CT pulmonary embolism, since each of these scans can miss defects. So it's actually important to use these two concurrently. CT will show an eccentric organized thrombus. And this tells us it's chronic because it's eccentric. And you would also see pulmonary artery enlargement, again telling us that it's chronic, and the mosaic attenuation, which we have discussed in the previous slide. Then you would also see vascular pruning, and all these are signs of chronic pulmonary embolism, in addition to the pulmonary hypertension. The ventilation perfusion scan will show segmental perfusion defects. So this image is a contrast enhanced axial CT image, and it shows an extensive eccentric mural thrombus here. And this second image shows dilatation of the pulmonary artery, the main pulmonary trunk, as well as an area of reduced attenuation as a result of perfusion defects here. So this is a case of chronic thromboembolic pulmonary hypertension. Now, there are some pitfalls of CT pulmonary angiogram. It's not a perfect study. Some of the problems you may encounter could be that the hilar lymph nodes and the mucus impacted bronchi may mimic a pulmonary embolism. Also, pacified pulmonary veins may also look like pulmonary embolism on a single CT slice, but you can distinguish between a pulmonary artery and a pulmonary vein by tracing the vessel back. If you trace the vessel back to the heart, you can tell that this is pulmonary vein and this is pulmonary artery. Also, during the Valsalva maneuver, there can be a transient disruption of the contrast bolus, and that would cause more dense contrast to be seen in areas like the superior vena cava. You would see no contrast in the pulmonary artery, and that would look like a pulmonary embolus. But if you were to time the imaging very well, you realize that the pulmonary artery would fill up. Also, cardiac and respiratory motion artifacts can also decrease image quality. The cardiac motion would cause blurring of the lower lobe pulmonary arteries, and this could also simulate small emboli. The respiratory motion would decrease the accuracy in evaluation of small pulmonary arteries. So this brings us to the end of our discussion of pulmonary embolism. The next thing we'll talk about is pulmonary hypertension. I do hope you are finding value from these videos. If you are, give it a thumbs up, share with someone who you think would like it, and leave a comment. I will see you in the next one.